So welcome. Welcome to Principals Consent Training. My name's Dr. Simon Walton. I'm a consultant anaesthetist, but I've also got an interest in medical ethics and law, having done a degree several years ago in the subject, and I use that to in various roles in the trust, and particularly I chair the Trust Consent Committee, where we review consent policy and consent incidents, and do quite a lot of teaching on consent. And today's session really is there to give you the fundamental principles surrounding consent. So that's the main objective of today. So we're going to explore some of the ethical principles, some of the legal issues that surround consent. We're going to talk about what guidelines are out there, and also what misconceptions are out there around consent. And hopefully this will be relevant for those of you who are taking written consent as part of your clinical duties, but also for people who are supporting or people through the process of consent, people who have to check consent, so people in theatres, people on the wards, people in pre-assessment. So I hope you find the session useful. And there'll be time for some questions at the end. Okay. So the first thing I want to look at is the ethical principles about consent. And the first question I want to pose is, morally, why should we take consent? And just have a think about that. Why do we need to take consent? What are the reasons we need to take consent? We think about maybe that we have to legally take consent. We sometimes worry that our professional bodies tell us we have to take consent. Our managers mean we have to take consent. But I would like us all to think about actually why we personally think taking consent is important. And I would argue the reason that we should take consent is really about it gives us an opportunity to respect people's autonomy. And why is that important? Well, these are two philosophers that I studied when I was doing my medical ethics degree. And they're quite old philosophers, but that doesn't mean they're not still relevant today. So one is Immanuel Kant, who was a Prussian philosopher over 400 years ago, 300 years ago, and he started arguing back then that actually all rational, self-conscious beings, we had the duty to grant them freedom of action and self-determination. And that was at the time was quite radical, when really the only people who had freedom of action was your king. You had to do really what your king told you to do or what the priest told you to do. But Immanuel Kant started arguing that if you truly were rational, we should respect people's rational decisions. And then another philosopher that I think is really relevant to understanding autonomy is John Stuart Mill, and he was what's called a utilitarian. And he felt that, and utilitarians feel that all morally right actions are those that maximise human happiness or human preferences. So he felt that the morally right thing to do was to allow people to make choices, because that was the best way of ensuring they were most likely to be happy and their welfare was supported. So generally, modern medical ethicists would argue that respecting people's autonomy is the supreme moral medical principle to follow. So it kind of trumps all our other principles that we think about, the principles of beneficence or doing something in somebody's best interests, not harming somebody. Those tend to be trumped by the principle of respecting people's autonomy. But to be autonomous, you need to have three necessary prerequisites, or three things that need to be in place to be autonomous. So the first is to have the capacity to reason. So that's linked to the law with the Mental Capacity Act. Secondly, you need to be free from undue influence, what ethicists call voluntariness. And finally, the third thing you need to have is to have adequate understanding. So unless you've got those three things, you don't have the ability to make an autonomous decision. Okay? So in summary, I think the ethical basis of consent is it allows us and it ensures that health professions respect our patients' autonomy. which is morally probably the most important thing we can do as health professionals. And it requires that the patient has capacity, that they're free from undue influence, in other words, voluntariness, and that they have adequate understanding. So one of the things we often talk about is informed consent. So many professional bodies say we need to take informed consent. You must take informed consent. So what actually is informed consent? Well, originally it was actually a legal idea that originated from the United States. And in many ways, some people's view of informed consent is a very legalistic view of informed consent. And they imagine it's all about just giving a 70-page document and getting them to sign it at the bottom, and then that's informed consent. And I see that a lot, particularly in drug studies, research. I'm also the chair of the Research Ethics Committee in Brighton, and we often review studies where we've got 50-page documents that participants have to read through and then sign to ensure they've got informed consent. But actually, that's not what informed consent's about. I would argue that informed consent is much more about giving people enough information in a way that they can understand it to be autonomous. And this is not just me saying that. There's a couple of bioethicists who've agreed that what informed consent's about. So one is Beachy and Childress, and they wrote probably the kind of most ubiquitous textbook that's out there, which is Principles of Biomedical Ethics. They're American, and they said that informed consent was a process by which the patient gives his or her autonomous authorization for treatment to go ahead. So notice that in red, process. Not a one-off event, it's actually a process. And they're using that term of autonomy. Another bioethicist I really respect is Ryan Gillick, who's a professor of medical ethics at Imperial College and a GP. And he describes informed consent as a voluntary, uncoerced decision made by a sufficiently competent or autonomous person on the basis of adequate information and deliberation to accept rather than reject some proposed form of action. So both of these authors are basically saying that you need to have an autonomous decision to gain informed consent. So it's the definitive process by which patients can exercise their autonomy. So what are the requirements for informed consent? Well, the requirements are exactly the same as they are for being autonomous. So in other words, to be competent or to have capacity, the same word, they just mean the same thing. Be free from undue influence, and to have adequate understanding. And I would argue that often we don't achieve that when we're trying to get informed consent. And I think particularly issues such as time pressure, situation pressure, can cause issues about getting informed consent, where people are being rushed to give their consent, and also whether they've had enough time and been given enough information in a way they can understand to make that decision too. So when we're trying to get informed consent, we should be thinking about these three prerequisites to get it, three necessary things we need to have. And I would envision informed consent, as the bioethicists talk about it, as a process of giving and explaining information leading to a decision to be made by a patient. So ideally, you want your patient to be able to meet the surgeon, let's say, or a nurse or any other healthcare professional in the outpatient setting, and that's when the consent process starts. So there's giving and explaining of information, and there's time and opportunities to ask questions. They go away with some written information that they can process, and they know they're free to change their minds, and then they're finally admitted for the process where their consent is reconfirmed. Okay? And that's often called the two-stage process of consent. So you get consent in your outpatients department, and then you come back and you reconfirm the consent when they come in for their procedure. And really, that's the kind of process we should be aiming for when we're getting informed consent. I'm afraid it doesn't always happen. And it's not always possible because clearly in more time pressure situations there may not be that ability to do that. This is the thing that often worries people, is what are our legal requirements about consent? And legally, I'd ask, do we even need to take consent? Well, in situations where it's an emergency and somebody doesn't have capacity, then actually legally we don't need to take consent. And in fact, in those kind of situations, a different bit of legislation comes into effect, and that's the Mental Capacity Act. And we have to follow the principles laid out in the Mental Capacity Act. And that's something that we're not going to necessarily cover in this session. But if a patient has capacity, then yes, we are legally obliged to take consent. Now, the legal principles that cover consent are covered not by an Act of Parliament, which we have, for example, the Mental Capacity Act, Human Rights Act, the NHS Act. All these are Acts of Parliament, and they'll have a clear set of rules which will tell us how we need to manage these patients legally. Common law doesn't have an act. Consent doesn't have an act that covers it. So most of the legal principles are covered by what's called common law, which is also known as judge-based law or jurisprudence. So essentially what happens in common law is that judges make decisions about what the right legal thing to do is. But how it works is generally judges will make a decision in accordance with previous decisions that have been made that have set a legal precedent. So you may have heard of the term legal precedent. And also the other important thing is it's the stature of the judge is really important. So the more senior the judge or the court that makes a decision, then the more likely it is that's going to set a precedent. Okay? So in terms of consenting, I'm just going to give this quote from Lord Donaldson back in 1992. So he's more master of the rolls. So back then, he was the top judge in the country, because it used to be the House of Lords was also the Supreme Court in this country. And he stated that an adult patient who suffers from no mental incapacity has an absolute right to choose whether to consent to medical treatment, to refuse it, or to choose one rather than another of the treatments being offered. And for consent to be legally valid in common law, there are three things that need to be there, three prerequisites. The first of all is the patient must have capacity. The second, the patient must have adequate information to make their choice. And finally, the patient must be able to give their consent freely. And you'll see those three things are identical to the three things for informed consent and the three things that are required ethically to have autonomy. So there's this theme going through the whole process. So if you get informed consent right, you'll also legally get your consent right. If you fail to get consent, then you can get two legal actions against you. One's a tort of battery, and the other is also a tort of negligence. So tort just means a civil wrong or injury arising out of an act or failure to act. So let's just look at battery, because that's the much rarer one, but it's often something people don't necessarily are aware of. But any non-consensual physical contact constitutes a tort of battery. So you don't need to establish any tangible injury. So it's about an invasion of personal space, essentially. The thing to be aware of with battery is that conduct constituting tort of battery will very often be potentially a criminal offence. So as well as a civil action of battery, there's also potentially a criminal action against you with battery. The good news for healthcare professionals is that the courts recognise that consent can be implied. Okay, so this is where that concept of implied consent comes from. So in other words, if a patient comes and lies on the operating table and puts their arm up there and you touch it, or they put their arm out for you to take a blood pressure, or to put a Venflon in, then that's all implied consent, okay? And that will not breach any rules regarding battery, okay? And even when it comes to major procedures, it's very hard to prove an offence of battery against people, as long as in very broad terms the patient has agreed to go ahead and have the surgery. So there are relatively few cases in English law that succeed when it comes to battery, but there have been a couple of very notable cases. They mainly involve, in the past they've involved the unconsented removal of female reproductive organs, so in other words hysterectomies where the females hadn't consented to that. And the other area again where you may potentially, or certainly where you can't necessarily imagine there's implied consent, are for intimate examinations. So clearly, if you're going to perform an intimate examination, you need to get fully expressed consent. You can't just rely on implied consent for those. The much more common type of legal case you might face when it comes to consent is a tort of negligence, or what we call generally negligence. And in any negligence case, the plaintiff, in other words, the person trying to sue the doctor or the hospital, has to prove three things. They have to prove you had a duty of care to the patient, there was a breach of that duty of care, and finally there was causation. And what causation means is because of your breach of your duty, your negligence, you caused them to have a physical or psychological harm. So when it comes to consent, they would have to prove you have a duty to gain valid consent. That's fairly easy. We've seen that. And if you're a healthcare professional and they're your patient, you have a duty to them. Secondly, they would have to prove that there was a breach of that duty of care. In other words, that the consent process wasn't of a sufficient standard. And finally, they have to prove causation. In other words, they were directly harmed by the failure to gain valid consent. So that's often quite hard to prove, because quite often you'd have to say, well, if I'd been explained properly, I wouldn't have gone ahead and had the surgery. And many patients under oath are unlikely to say that, because even if they'd known the risk, they probably would have gone ahead and had the surgery. So it can be difficult to prove causation. However, there was an important case called Chester v. Afshar in 2004. And in this situation, this was a neurosurgeon who performed a back operation perfectly appropriately, not negligently, the actual surgery, but unfortunately the patient, Mrs. Chester, had suffered a recognised complication of cauda equina syndrome. And unfortunately, Mr. Afshar could not show any documentation that he'd discussed this particular risk with Mrs. Chester. Although he said, oh yes, of course I did, when he was asked by the judge didn't believe him. And he hadn't got it on the consent form and he hadn't put it in his notes. What was interesting about this case is Mrs. Chester, when she was questioned, said, well, if I'd known about the risk of cauda equina syndrome, I probably would have still gone ahead and had the operation, but I may have thought about it a bit more, delayed it on that day, gone and got a second opinion. So you could have argued she didn't actually prove causation, but the judges still found in her favour, and they felt that the fact that the doctor had failed to give a really important information was negligent, full stop. So potentially now, if you fail to give a really important piece of a risk that's relevant to that patient, you can be found negligent, even if the patient would have gone ahead and had the operation anyway. So the hardest thing for us as healthcare professionals is knowing what kind of standard of information should we impart. How do we do the process well enough not to face a legal challenge? And it's difficult to answer, but what is definitely clear is that the courts expect an increasingly higher standard. So clearly professional guidelines are important. So when you're discussing risks, if you've got a relevant body that's issued some guidelines for that particular procedure and what you should discuss, you should certainly follow those. But even with that, we need to be very careful because of this very important case that was came about in 2015 of Montgomery v Lanarkshire Health Board. And I'm just going to discuss the case a little bit because it's probably the most relevant case now to the law and consent. So basically the case involved treatment advice given by a consultant obstetrician and gynaecologist, Dr. Dean McClellan, to an expectant mother called Nadine Montgomery. And the advice concerned the type of delivery suitable for her son, whether to have natural birth or to have a caesarean section. So what happened? So at 36 weeks, Mrs. Montgomery went to see Dr. McClellan for an ultrasound scan, and at that point it was noted that the fetus was large. It was also noted that mum was short and diabetic. She went on to have a vaginal delivery on the 1st of October 1999. So it kind of illustrates the fact that this case took 16 years to finally go through all the courts. But sadly, during that delivery, her son had shoulder dystocia and suffered prolonged hypoxia and ended up with cerebral palsy, injury to the brachial plexus and paralysis of the arm. So what was the issue at stake? Well, it was all about that meeting at the ultrasound scan, and Mrs. Montgomery team argued that the doctor had been negligent because they did not discuss the possibility of dystocia and the option of a caesarean section. Okay? Now, at that time, although the baby was large, it was not necessarily large enough to trip automatically to have an elective section. Okay? But the problem was that the doctor didn't even discuss the option of having caesarean sections. She just said, no, you'll be fine, you just go ahead and have a vaginal delivery. The defence team argued that the doctor hadn't been negligent because it was not routine to discuss caesarean section as an option. Okay? And then she had plenty of experts to back that up. And the main concern was that if you give everybody the option of having caesarean section, this will invariably lead to a rise in people wanting to have caesarean sections, which for the general public good is probably not necessarily a great idea. Okay? So there were some important justifications on both sides of the argument. But in the end, the judgment went in favour of Mrs. Montgomery. Okay? And so this is why it's quite important just to go through the judgment, because although this seems to be a very specific case about obstetrics, because it's set a legal precedent and it came from the UK Supreme Court, so that's currently the highest court in the land, it means that any kind of issues about consent or any legal case with consent will refer back to this important judgment. So it's worth just going through. So in this judgment, one of the things that the judge said was an adult person of sound mind is entitled to decide which, if any, of the available forms of treatment to undergo, and her consent must be obtained before treatment interfering with her bodily integrity is undertaken. The doctor is therefore under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment, and this is really important as well, of any reasonable alternative or variant treatments. So it's not just good enough to give a list of all the complications of the particular procedure you're planning to do. You also need to make sure when you're consenting the patient that they've discussed alternative options, and including potentially the option of no treatment at all. The other thing is they talked about this thing called material risk. So we now often talk about, if we're talking about what risk we need to explain to a patient, what the judges are saying, you need to explain material risks. And the test of materiality, according to the judge, is whether in the circumstances of the particular case, a reasonable person in the patient's position would be likely to attach significance to the risk. The doctor is or should reasonably aware what the particular patient would likely to attach significance to it. So what's that saying is it's not just good enough just to say, well, these are the things I always talk about of all my patients. You need to make sure you've worked out what is particularly relevant to that particular patient. So, for example, in my own practice, we often intubate patients or we put laryngeal mask about patients. And when I'm consenting a patient for an anaesthetic, one of the risks that can happen from intubating is that a patient may lose their voice. That can be usually very temporary, potentially very rare cases could be a permanent loss of voice. Very, very rare. And generally in routine practice, most anaesthetists, including myself, wouldn't necessarily discuss the permanent loss of voice as a risk. However, if I'm about to anaesthetise somebody who's a professional singer, then clearly that is a material risk to that particular patient. And therefore, that is a risk that I would be under a legal duty to make sure I've discussed with that particular person. So that's what we mean about material risks. So you can't just say, well, I won't give a risk because it's so rare. You've got to decide whether, even if it's rare, it's important to that particular patient and relevant. And again, the judges say that. The assessment of whether a risk is material cannot be reduced to percentages. So you can't just say, I'm not going to discuss risks that have got less than 1% chance. The other thing they go on to say in red is the assessment is therefore fact sensitive and sensitive also to the characteristics of the patient. So you've got to think about what you would normally do, but also for each individual patient. So what they're really saying is about having a conversation with your patient, finding out what's worrying them, finding out what's relevant to them. And that's really what all our professional bodies ask us to do, is to have conversations with our patients when we're consenting them. So that's the legal side. I want to now go on and discuss briefly what day-to-day guidance is out there for health professionals. And probably the most important thing is our policy and consent in the trust. And this is based on an original policy produced by the Department of Health back in 2001. And in 2001, the Department of Health said that all consent policies in every single NHS trust had to be absolutely the same. And they produced a model consent policy, and they also produced a set of model consent forms, which were first released in 2001. And those are still the forms that we use even now, 19 years later. Okay? But as you can imagine, the problem with the model consent policy the Department of Health produced back in 2001 is that it's out of date. So we've personally had to update it regularly. So if you want some guidance, I would always suggest that you go and look on the intranet at our consent policy. And it has clear, up-to-date guidance based on Department of Health guidelines to give you guidance on the consent process. The only other thing that the Department of Health has produced about consent as a guidance was this document in 2009, which updated quite a lot of their earlier guidance and included guidance about the Mental Capacity Act and Human Tissue Act and some other important cases. But it's still out of date even now because it doesn't have the Montgomery v Lanarkshire case, which is from 2015. For those who are particularly taking surgical consent or involved in the surgical consent process, I would recommend this document produced by the Royal College of Surgeons. And this has very much updated guidance on how to obtain informed consent. And again, is available on the intranet. So part of this session is about people taking written consent. So I think it's very important that we do focus on the specifics about written consent, and particularly some of the misconceptions that are out there about written consent. So I think kind of one of the things I often come across as an attitude is that really all it's important about taking consent is that we've got the person to sign the bit of paper before the procedure starts. And particularly those of us in theatre will often say we're checking has the patient signed a consent form. But I would argue that actually a signature is evidence that some kind of consent process took place, but it's not evidence that the consent was adequate. It's a good start, but it doesn't necessarily prove that consent is completely valid. What's interesting actually is that there is rarely any legal requirement in law for consent to be in writing. So actually consent can be both given verbally or in writing. But written consent, in other words, getting the patient to sign a consent form, is recommended by the Department of Health and in our own consent policy if the procedure has one of these 4 particular points involved with them. So if the procedure is either complex or involves significant risks, if it involves general or regional anaesthesia or sedation, where there may be significant consequences for the patient's employment, social or personal life, or if it's part of a research project. So those are the 4 things that would require, if you have any one of those 4, you to obtain written consent. So most of the things that go into theatre will obviously require written consent. But it also means we don't have to get written consent for everything. And I think we do need to avoid going down the line of trying to get written consent for every single healthcare procedure we do, because actually that makes it almost unmanageable, the whole process. The other thing about written consent is that our own policy and the Department of Health guidelines talk about the 2 or more stage process of consent, which I mentioned earlier in terms of informed consent. And the Department of Health recommend that the consent process will therefore have at least 2 stages. The first being the provision of information, discussion of options and an initial decision, and the second being confirmed that the patient still wants to go ahead. And they recommend that the consent form should be used as a means of documenting both the information stage as well as the confirmation stage. So the Department of Health is telling us to get these consent forms done in the outpatient setting. The other thing that you can use on the form, which people often forget, is you can also document on there what written information you've given to the patient in outpatients. And one of the things we do is when we audit our consent forms, we look at how well they're filled in. And one of the areas that are very badly filled in is what information leaflet has been provided to the patient about their operation. So any of you taking written consent, please can I encourage you to make sure you, if you do give a leaflet, that you include that on the consent form. One of the things that people worry about is the validity of a consent form. So how long is it valid for that consent form to still be able to be used when the patient comes in for their procedure? So I've often heard various different random things put in 2 weeks, 6 months, or any other kind of random time limit. I can assure you that there is no time limit to a consent that's been given. Okay? And this is what our own Department of Health and our own policy states, is when a person gives valid consent to an intervention, in general, that consent remains valid for an indefinite duration, unless the person withdraws it. Okay? So if the consent form has been first signed by the patient 3 months ago, it's still valid if they haven't withdrawn their consent. More to the point, they actually say it is good practice where possible to seek the person's consent to propose procedure well in advance when there is time to respond to the person's questions and provide adequate information. And then you should then check just before the procedure starts that the person still consents. And all of you will be familiar that do check consent is you've got this confirmation of consent bit on the consent form where a healthcare professional can sign that to say that the patient still confirms they want to go ahead with the procedure. And I'd argue that what we shouldn't be doing, certainly, is filling them in at the last moment. And this is from the Department of Health. Again, their policy, our policy, if a person is not asked to signify their consent until just before the procedure is due to start, at a time when they may be feeling particularly vulnerable, there may be real doubt to its validity. So ideally, we shouldn't be getting stent just before the procedure starts, e.g. when they're in a gown or on a trolley, or even worse, if they're in the anaesthetic room. Final thing I want to talk about is pediatric Oh, sorry. One of the things I want to talk about finally is who can actually do written consent. And first thing to say is that the healthcare professional who carries out the procedure is ultimately responsible. So if the surgeon's doing the procedure, they're ultimately responsible for ensuring valid consent has been obtained. And if it's a nurse doing the procedure, if they're actually responsible for ensuring valid consent has been obtained. But it's recognised that the actual taking of the consent can be delegated to another healthcare professional who's not doing the procedure. Okay? And in fact, that's often can be a benefit. Surgeons are often busy, they may not have enough time to do the process properly. If you can delegate it to some other person, that might actually improve the consent process, as long as there's somebody who is trained to be able to answer the questions. Okay, so if you are going to take written consent and you're not doing the procedure, you've got to make sure you're competent to be able to do that. And you can only be competent to do that if either one, you can do the procedure, or the second way is you've been trained in taking consent for that procedure. Okay, so we do see areas like endoscopy, in ophthalmology, where nurses are taking consent for procedures, and actually the process really is very well, it's going very well with both patients and with the healthcare professionals. But it does need to be, you need to be properly trained, and you need to be sure you've been assessed and that you're registered within the division to be able to take consent. Final thing we want to talk about is paediatric consent. So there are some common misconceptions out there. These are three statements I often hear. Over the age of 16, you are considered an adult and have the same rights. For children under 16, you need the parents' permission. And basically, whichever adult, mum or dad, is with the child, they can sign a consent form. Now, all three of those are misconceptions and not true. So, in law, you are not an adult and you don't have the same rights of adult until you are 18. Now, under the law, the Family Law Reform Act, it is recognised that 16 and 17-year-olds are presumed competent to give consent for any medical treatment. So it's not necessary to obtain consent from parents if they're 16 or 17. However, this doesn't give 16 and 17-year-olds the right to refuse treatment. So unlike an adult, if you as an adult and you're competent, if you refuse treatment, that cannot be overruled by anybody. But if you're a 16 and 17-year-olds, that potentially can be overruled by a court. Very rarely, but potentially they can be. So what about children under 16? Well, they are generally presumed incompetent unless they show what's called Gillick competency. And this basically arrived from a case called Gillick v West Norfolk and Wisbech Area Health Authority, which was back in the 1980s. And in that case, it was about generally the prescribing or giving oral contraceptive to children under the age of 16 without their parents' permission. And the judgment that came out, that came from the House of Lords, and this set, again, because it was the top judge and the top court in the land, an important precedent. And the House of Lords said that the parental right to determine whether or not their minor child below the age of 16 will have medical treatment terminates if and when the child achieves a significant understanding and intelligence to enable him or her to understand fully what is proposed. So we have this thing called Gillick competency or Fraser competency, named after the judge. Victoria Gillick, who was the woman who brought the case, doesn't like her name being used, so we should really call it Fraser competency. And it's a grey area, and it will vary depending on treatment in question, but if you feel that a 15-year-old or a 14-year-old has the capacity to understand what's involved and to agree to that treatment, you can allow them to consent to that treatment and not need their parents' permission. Okay? However, need to stress again, this is authority to accept treatment, not to refuse treatment. So just like 16 and 17-year-olds, their refusal of treatment can be overruled. What about children who lack Gillick competency? So these are younger children. So who can consent on behalf of them? So who do you go and speak to gain a consent? Well, you need to get consent from somebody with parental responsibility. That's the terminology we should use. So who has parental responsibility? Well, automatically birth mothers have parental responsibility for their children. So that means the woman that gave birth to the child. It doesn't necessarily mean the biological mother, because obviously we have donor eggs, we have donor sperm, so biologically that may be a different mother, but in law it's the mother who's become pregnant, born the child and delivered the child who automatically has parental responsibility. Fathers, this is where it's a bit more tricky. So if they're married to the mother when the child was conceived or born, or even if they get married to her later, then generally they will automatically have parental responsibility for that child. Unmarried fathers in law don't automatically have parental responsibility for the child unless their name appears on the birth certificate. If their name doesn't appear on the birth certificate, then they have to go and get a court order or a parental responsibility agreement. So it is important, if you're getting from a male, consent from a male, that you're happy that they generally have parental responsibility for that child. Local authorities also have parental responsibility for children who are in care, or what's now called looked after children. So if you have a child who's placed with a foster parent or in a child care home, then actually the local authority will have parental responsibility and you'll need to get consent from them. Potentially courts can also be given parental responsibility. So somebody who's been named a ward of court means that actually a judge has parental responsibility, and you would potentially have to go to a judge to gain consent for that child. What I really want to emphasise is people who don't have parental responsibility, yet we still see incidents when consent's been obtained from them. So grandparents don't have parental responsibility, aunties don't have parental responsibilities, the best friend next door doesn't have parental responsibilities, and also foster parents don't. So you can't get consent from a foster parent. So it's just important to remember that. Okay. So in summary, we have an ethical and legal obligation to obtain proper informed consent. So I hope I've really hammered that home about the ethical side of it, because I think it's really important we do things we think morally it's the right thing to do. Consent is a process and not a one-off event, so we need to be looking at trying to follow that two-stage process as often as we can. If we are going to face a legal action, then most are brought because of a failure to provide information of a sufficient standard. And particularly now, not talking about the full range of available treatments and options. And it's also important to remember that we can delegate consent to appropriately trained staff. It doesn't just have to be the person doing the procedure takes consent. That's it. Thank you. And we'll take time for some questions.
Decided to let it go on with the surgery. Well, she's 16, so they said 16 and 17. Can you repeat that part where the patient's decision can not be overruled? Can be overruled?
Yeah, so let me go over that again. So 16 and 17-year-olds are generally don't have the right to refuse treatment. Don't have the right to refuse it. If you're 18 and above, you can refuse treatment as long as you have the capacity to make that decision. However, the courts are highly unlikely to overrule a 16 and 17-year-old unless there's a really, really good reason to do that. And a kind of situations where that potentially has happened are incredibly rare, but they've generally involved life-threatening disease that requires treatment. And even in those cases, which have been brought to court, sometimes the court have found in favour of the child's refusal. So generally, although I've said they don't have the legal right to refuse treatment, by far the most right way to approach a situation where you've got a 16-year-old refusing to have treatment is to respect that, particularly if it's not a life-threatening situation. So if they're just having a cosmetic procedure or a lump removed or whatever, then actually, we shouldn't go ahead, because the harm is to the child and having their wishes overruled. It'd be like us, having our wishes overruled. It's extremely damaging, and it's not respecting their autonomy. But unfortunately, the law doesn't allow. This doesn't quite give the same value to 16, 17-year-olds' autonomous decisions as it does to adults. Does that make sense? So generally, when I've had children who refuse, you just have to, the common one is they often, even younger children than 16, 17-year-olds, generally I'm very reluctant to go ahead if they refuse to have the anaesthetic or whatever, particularly if it's for a non-urgent elective procedure, but it's just because of the distress it causes to the child. When they're very young, it's slightly different, but, even as young as, 7, 8 or 9, very reluctant to force them to go through a procedure that they're not happy to go through.
Very common in dental patients, they refuse to
Yeah.
go through the procedure.
Yeah, and sometimes, often you can give them a bit of pre-med or give them a bit of time to think about it and they come back, but just not giving them any time to think and just going ahead can often be quite damaging. And actually, legally, again, the law regarding people under the age of 16 and their refusal to treatment is again slightly complex, because the court has respected 14-year-olds and 13-year-olds' decisions to refuse treatment. So we've got to be careful.
I guess. Thank you.
No problem.